All right, welcome, and thank you for joining us today. My name is Bessie Yang Lewis, and I will be your moderator for today's panel. My Pheo Para story began when my husband Scott was diagnosed with metastatic paraganglioma in March of 2021. He underwent several treatments, including chemo and later Azedra, but his disease was already very advanced, and he passed away 14 months after his diagnosis in May of 2022. While we did not have the hope for outcome, we were thankful to have Azedra as a treatment option. And in fact, Dr. Pryma, who's on today's panel, was the physician treating Scott and took great care of him. So I can deeply relate to patients and caregivers facing questions on what treatment options are available now. I am here with Doctors Jimenez, Mittra, and Pryma. We will provide a proper introduction in a few minutes. This program is brought to you by Pheo Para Alliance, whose mission is to empower patients with pheochromocytoma and paraganglioma, their families and medical professionals through advocacy, education, and a global community of support, while helping to advance research that accelerates treatments and cures. I do want to provide a summary of upcoming events. We will be in Gainesville, Florida on Saturday, October 28th, where Dr. Hans Guy, Dr. Carol Potzak, and other experts will speak at our last in-person regional conference of the year. Our next monthly peer support meeting will be on November 7th at 7:30 p.m. Eastern, 4:30 Pacific. November 10th is World Net Cancer Day. Watch your social media for information on how you can help spread awareness about neuroendocrine cancers like Pheo Para. On December 5th, we will hold our 4th annual fireside chat with Dr. Carol Potzak, who will spend an hour answering your questions. And finally, on December 12th, we will present our last educational webinar of the year, The Multiple Faces of SDHB-related Paraganglioma, at 9 a.m. Pacific, 12 p.m. Eastern. You can learn more about all of these events and register to attend on our website, www.pheopara.org. Today's agenda will be a little different from that of our other webinars. We will invite our panelists to make some opening remarks and then move immediately to the questions you have submitted. Remember, you can also type your questions into the chat section at any time. We will do our best to answer as many questions as time allows. Many people will ask variations of the same question, so listen carefully for questions that are similar. Finally, bear in mind that we are all still processing this news and gathering information. We anticipate that today's discussion will be a lively one with varying viewpoints on what is still a developing situation. The information presented on this webinar is for educational purposes only and should not substitute for the advice of your doctors and medical team because they have in-depth knowledge of your medical history and current situation. As many of you are aware, on August 28, 2023, Lantheus announced to the financial markets that production of Azedra, the only FDA-approved therapy for metastatic unresectable Pheo Para, would be halted in the first quarter of 2024 due to a lack of commercial demand. As we understand it, Lantheus is still operating with the goal of providing enough doses for current patients so they can complete their course of treatment with the therapy. As a result of this news, Pheo Para Alliance moved quickly to form the Advocacy Task Force, a committee comprised of patients, caregivers, and healthcare professionals, some of whom are members of the Board of Directors, Medical Advisory Board, or PPA staff. The Advocacy Task Force mission statement is as follows. The overall purpose of the Advocacy Task Force is to create a strategy to support Pheo Para patients who will be affected by the unavailability of Azedra. This support may include gathering information about access to alternative treatments, advocacy for the continued manufacture of Azedra, coordination with other organizations that may assist in the development of a strategy, patient education and communication, and, more generally, addressing policy and political possibilities for protecting medical options for those with rare diseases. More information can be found at www.pheopara.org/community/take-action. It is my pleasure to introduce our panelists. Dr. Camilo Jimenez is the professor of endocrine neoplasia and hormonal disorders at the MD Anderson Cancer Center in Houston, Texas. He has performed extensive clinical research in the field of endocrine cancer with a particular interest in pheochromocytomas and paragangliomas. Dr. Jimenez was one of the first clinicians to describe the use of tyrosine kinase inhibitors in patients affected with sporadic and hereditary malignant Pheo Paras. His observations led to the development of prospective multi-institutional and international clinical trials. Dr. Jimenez also characterized inherent complications related to excessive hormonal secretion and tumor burden distinctive of this disease. Dr. Erik Mittra is professor of diagnostic radiology at Oregon Health and Science University, where he serves as the chief of molecular imaging and therapy section and director of the targeted radiopharmaceutical therapy program. Dr. Mittra is interested in all aspects of nuclear medicine with a focus on targeted radiopharmaceutical therapies and theranostics. His research interests are focused on the translation of novel radioisotopes for imaging and therapy. He is involved with the Society of Nuclear Medicine and Molecular Imaging and the North American Neuroendocrine Tumor Society, among several others. Dr. Daniel Pryma is the Gerd Molliner Professor of Radiology. He serves as the Associate Director for Clinical Research in the Abramson Cancer Center and Chief of the Division of Nuclear Medicine Imaging and Therapy at the Perelman School of Medicine at the University of Pennsylvania. His research focuses on therapeutic radiopharmaceuticals and companion diagnostics. He is also co-leader of the Radiobiology and Imaging Program of the Abramson Cancer Center and serves as chair of the Imaging Committee for NRG Oncology. And finally, Amy Powell is Community Engagement Specialist for the Pheo Para Alliance. She's been working in the community for nearly 10 years and was caregiver to her mother and her brother John, both of whom had Pheo Para, caused by an inherited SDHB mutation. In addition to her role with the PPA, she sits on the Society of Nuclear Medicine and Molecular Imaging Patient Advocacy and Advisory Board and is a member of the Pheo Para Alliance Advocacy Task Force. Welcome, everyone. So I would like to start with the first question, which I think is a good way for you all to give your opening remarks, which is, what happens now that Azedra is no longer available? And I'll leave it to one of you to jump in as you see fit.
I mean, I guess I'll jump in. It wasn't available clinically before 2018, and we did our best to care for patients. So we're gonna get back to that. The sad thing is some of the resources that we could use, like low specific activity MIBG, as a compounded pharmaceutical before 2018, those resources kind of went away when there was a manufactured approved drug, and it's not so trivial to bring them back. And so we're scrambling to see if there are opportunities. Thankfully, the world hasn't stood still since that approval, and there are other drugs that are being tested or have been tested, and that give us hope. So there will be options, and we'll just do our best. I'll let Erik or Camilo join in as well.
Yeah, I would completely agree with what Dr. Pryma said, is that, you know, this situation is very unfortunate, of course, and I know it can bring a lot of anxiety to patients and their caregivers. But as he said, you know, this is relatively new molecule that was approved in 2018, and prior to that, we treated patients, and now the situation has changed also with the availability of Lutathera, which was also approved in 2018. And in fact, I think that's one of the potential reasons why, in my view, that Azedra was not utilized as much as it probably should have been or could have been. So nonetheless, we have a evolving market, and so we'll continue to do what we can. And also there is some work I know that's being done throughout the community in terms of potentially continuing Azedra. It's completely unknown right now whether that will work or not, but I think things will continue to evolve in the future.
I will simply add that although there are some options available, we have to be careful, because although those options exist, in reality the access to many of them is still quite limited. When we talk about Lutathera, yes, Lutathera is not FDA approved for pheochromocytomas or paragangliomas. It's in reality approved for the broader tumors of the pheochromocytomas or paragangliomas that include, for instance, the pancreatic neuroendocrine tumors, the gastrointestinal neuroendocrine tumors, and others. And by law, as the medication is FDA approved, if we have a potential indication, yes, in this country, in the US, we may be able to prescribe it to other patients who have, for instance, somatostatin receptor expression, which are, for instance, the patients with pheochromocytoma and paragangliomas. Nevertheless, the lack of an FDA approval can make quite difficult the access to Lutathera to many different patients, many times because they have health insurances that are not willing to cover for the medication, or which is a very real life at this time in the US, a large number of patients in this country, without distinction, do not have health insurance or access to adequate health system. Many patients are simply protected by Medicaid, and of course, Medicaid will not be able to provide that. Therefore, we need to continue looking for options, and one of the options that we have to encourage very much in this country is the identification of medications that we can test and we can evaluate, especially through clinical trials. We need more clinical trials to understand better how to treat these patients. So that's a take-home message that I want to leave here, the importance of the clinical scientific development.
Thanks very much. And we do have some other follow-on questions regarding clinical trials and Lutathera and other therapies that we will cover in this webinar. Second question is, so I had mentioned in my previous statement that our understanding is that patients who are currently undergoing Azedra treatment will get the doses that they need to complete their treatment. But is Azedra no longer available to new patients?
That is my understanding from talking with Lantheus, is that the patients who are already in the pipeline and have been assigned a dose, they will continue to get their dose, even the second dose, which may be into the first quarter of next year. But new patients are no longer being allowed. That's at least what we've been told.
The last patient I enrolled in AZEDRA was yesterday, and I think it's going to be the last one in the whole country.
I think that goes into the next question, which is, why are they stopping production of Azedra?
That's a tough question for us to answer. We could give some very cynical answers, I'm sure. Ultimately, I guess it's a business decision, which is unfortunate because Pheo Para is not any less rare than it was when this drug was first developed. And there are realities to developing drugs for rare diseases, and we appreciate that it was done, but makes it extra heartbreaking when it's undone.
Yeah, that's
I'd
again.
like to add, go ahead, Erik.
Okay, sorry. No, I was just going to echo that, is that's my understanding, is ultimately a business decision in terms of how much utilization. I mean, I think everyone can appreciate that these radiopharmaceuticals are very challenging to produce. And so it takes a huge amount of infrastructure and a lot of work on the part of whichever company is producing them. And so there has to be, sufficient demand to accommodate that. And I think there wasn't. And again, I think, and this is entirely my opinion, that again, some of the utilization was taken away by the availability of Lutathera as well. Completely agree with what Dr. Jimenez said, is that it's not FDA approved. It's a very important thing for people to understand. Nonetheless, many people were being prescribed it off label. And I personally think that kind of ate away at some of the utilization for Azedra.
And I would like to add, based on the conversations that I have had with several patients that come to MD Anderson, that unfortunately there was also a lot of misinformation related to the use of Azedra in clinical practice. And this is an opportunity to discuss this in order to prevent mistakes later, because this is a rare and orphan disease. So one of the concerns that I have as a clinician is that the message that is sent to mainly pharmaceutical companies is that to invest on clinical trials for pheochromocytomas and paragangliomas could be quite challenging, and there may not be really opportunities to obtain a gain of investment, if you want to put it from that perspective. And no, in reality, we see patients with pheochromocytomas and paragangliomas. I think the case of Azedra suffered somewhat from the fact that there was a lot of misleading communication outside. To give you examples, many people indicate that if you are SDHB positive, and SDHB positivity in the context of metastatic disease may happen in up to 50% of patients, you may not be treated with Azedra or MIBG because the tumors are supposed not to express the noradrenaline transporter, therefore they are supposed not to be MIBG avid. That is not true. In reality, in my practice, which is quite extensive, and I'm sure the practice of Daniel Pryma and Erik Mittra is similar, we'll see many patients who are SDHB positive, who have MIBG uptake. And if you ask me, the two most impressive responses I have had in clinical practice, people with complete responses, I'm not sure if they are cured or not, are patients who are SDHB positive. Another important thing is the comparison in between MIBG scans and DOTATATE PET scans. Of course, the latter is much more definitive, much more obvious, and the one of the MIBG scan is quite blurry in some way. And people say that if you have more DOTATATE avidity obvious to people with not a lot of experience in this, many times just clinicians who see, were not used to see these rare cases, of course, they will use more often Lutathera when compared with Azedra. Perhaps I'm wrong, but I think we have to be careful with those aspects. And to tell people that if you are old or you are very young, you are going to be more prone to have toxicity with Azedra or MIBG, that's also not true. In my practice, the oldest patient who is 84 years of age and who only weighs 40 kilograms, which is about 80 pounds, is the one who has tolerated the medication the best, with no symptoms whatsoever, currently 2 years out of therapy, with a progressive response over time. And I'm almost sure that, yes, someday he will die because that's the way life is, but he will not die because of the metastatic pheochromocytoma. So in other words, organizations like the Pheo Para Alliance and people like us are extremely important to really deliver the right messages to the people who need to know more about this disease.
Thank you. I would like to direct the next question to Amy Powell and then give the doctors a chance to weigh in if they would like. But the next question is there anything we can do, grassroots campaign, for example, to stop or delay the cessation?
So we're looking into that. I would say to keep an eye on the advocacy task force page and our social media channels. We'll be announcing any efforts like that where we would like the participation of the community on those channels and on that website. And again, just spreading awareness about this. If you have an Azedra story, if you've taken it or a loved one has taken it, we would love to hear your story. So you can submit that through the Tell Your Story form on our website. If you go to Connect and then Stories, you can find that link. We'll also include it on our social media today if you're looking for it. So those are some really good ways. We are investigating ways, grassroots campaign type things. And again, we're also going to be providing additional resources on the advocacy task force page for clinical trials, other drugs that might be effective. We'll be providing a letter for patients to give to their healthcare providers if they're considering an off-label therapy, and insurance is an issue because that can be an issue. But if it's a part of what's considered to be standard of care, it is something that ultimately your insurance company should cover. It will sometimes maybe just take a little bit more effort than normal. So we will definitely be there to help you through that process. But all I can say is just stay connected with us and pay attention to what's going on, because we are working on this and we'll be putting some new things out imminently. So.
If I could add, yeah, in my opinion, I think it's going to be super challenging to, make Lantheus reverse its course on this decision. Again, it was I'm sure, well thought out business decision and unlikely, I think, to change. But I do think that the campaigns may help affect it. And this is actually one of the questions in the Q&A that I'm seeing. Is that, is there any possibility that other drug companies can take it on? And I do think that there is some hope for that. I think it's very early on because those companies also would need to do their due diligence and evaluate everything. But I mean, if there is sort of a significant campaign around the importance of Azedra therapy, then I think that might affect it in a positive way. But and also agree that the comment that was made that in our experience, at least, Lutathera was generally reliably approved by insurance companies, even when Azedra was available. But now that Azedra isn't, there should be even a slightly lower barrier, I would imagine, because there isn't a good FDA-approved alternative.
And I would add to that, I mean, two things. One is that we need time. Anything that's going to happen, whether it's a replacement manufacturer or some changeovers or anything like that, isn't going to happen overnight, and getting it done by early 2024 would be very, very difficult. So I think regardless of what happens, there will be a period where AZEDRA is not available. I hope it becomes available again in the future, but unless something significant changes, it's hard to imagine that there's not a period where, well, I guess a period starting now where it's not available to new patients who need it. I will agree with Erik that most of the time, insurance companies are worried about precedence. They're worried about covering a drug in a patient with breast cancer than having to cover it in all those patients. And so a lot of times it really is to the point of getting in front of someone there and making them understand how rare this disease is, that setting precedence isn't going to be a very costly thing for them. But getting to that moment takes a lot of advocacy, and patient will need to be involved, their doctors will need to be involved, and it's difficult. And getting the attention of people, because it is a rare disease, even within the hospital, the people managing the healthcare relationships are focused on things that are hundreds or thousands of patients a year. And so just getting that attention and making them understand that there's a person who doesn't have other good options, and it can really be effective, but it's a hands-on process.
If I could just add before we move on, many states have consumer advocacy wings of their insurance, the state insurance regulation department. So I am working to put a list of all of those resources for all 50 states together. And that, again, will be something that we'll link to on the advocacy task force page under the resources section. And I know in California in particular, just because I have more experience with NETS patients overall here, people have had a great luck working with that department to ultimately compel the insurance companies to cover therapies. Lutathera actually got covered before it was even FDA approved here, just based on its effectiveness and the work that had been done in other countries. But it does take work, and we'll be there to do as much of that with you as we can, and give you the resources that we can to make the process a little bit easier.
All right, thank you.
I just want to
the
highlight,
next-
can I highlight two things really quick? One, relative to what Dr. Jimenez said about clinical trials and their importance. There is a ongoing trial for Lutathera in the Pheo Para space at the NIH. It's actively recruiting right now, and those types of data are exactly what's truly needed to expand the indications and so forth. So I would really advocate for clinical trials in general, and that one specifically in this specific area. And then I think I'll stop there. There's some questions about the differences between Lutathera and AZEDRA, which we can address if there's time.
Yes, so the next set of, and this is a great segue, the next set of questions do focus on the treatment options. So the first one is something better than AZEDRA coming soon? I have a vagal paraganglioma that is avid to Gallium DOTATATE. Targeted chemotherapy would suit me, but what options will I have when AZEDRA is gone?
So I guess I can address the Lutathera question, which is in the guidelines, in the NCCN guidelines, it includes Lutathera as an option for Pheo Para. Having said that, we don't really have a lot of data, and the data we have is not great data. So it may work, it may not work. We don't know yet. What we have now are individual patient experiences, and I think all of us probably have had some where we've had some patients who seem like they benefit, some patients who don't. And that's why we do clinical trials, is to get objective data to really understand that, because no cancer treatment works for everyone or doesn't work for, well, I guess some don't work for everyone. It's not one of those, but we don't know how well it works. And so it is reasonable. There is as Dr. Jimenez pointed out, the DOTATATE PET scans, part of the beauty of them is the PET technique itself, which is just a really, really great way of imaging. So the scans look great and you can find things, but what you need to see something on a scan and what you need to deliver enough radiation to really knock a tumor back are different. And so a scan done at 1 hour doesn't always predict how that treatment drug is going to sit there for 2, 3, 4 days and deliver radiation. And so sometimes that's what we worry about, is that you can have a scan that's very positive, but if that washes out quickly, you're not going to get a lot of radiation dose in there. And so that's part of the challenge. I hope we do get more data soon on how effective Lutathera is. I think it definitely, there is efficacy. And so I think we should think of it as an option, but there's not enough data now to say how good is it, how does it compare to other options.
Thank you. And I think actually, Dr. Pryma, you answered the next question, which is Lutathera as effective for people who responded well to AZEDRA, which it sounds like more data is needed. The next question is, how might side effects from treatments like Lutathera differ from those associated with AZEDRA?
I can take a stab at that. So again, and maybe I can also kind of address the other question in terms of the differences between these two, just so we're all on the same page. There are both radiopharmaceutical treatments. The actual isotope that is attached to them is slightly different between the two. And of course, the target is slightly different. So generally speaking, they are kind of similar, but in those details is how they are different, and also the administration is different. AZEDRA is given over 2 cycles at a much higher dose, whereas Lutathera is given up to 4 cycles at a lower dose. So generally, Lutathera is done as an outpatient treatment. Generally, AZEDRA has to be done as an inpatient treatment because of the higher dose. In terms of the toxicity, and I think Dr. Pryma can probably address this better, but again, we worry mostly about bone marrow toxicity when we deal with radiopharmaceutical systemic treatments, and that's true for both of them. We expect a reduction in blood counts after each cycle of the therapy. Beyond that, though, I think it's quite variable, again, depending on the patient and their distribution of disease and so forth. Yeah, I'll turn it to the others to add to that.
Do you want to mention anything on the bone marrow based on the trial?
I mean, I think the bone marrow, because we're giving, it's sort of like with Lutathera, you're tapping on it 4 times with a lighter hammer. With AZEDRA, you're whacking it twice with a bigger hammer. And so the bone marrow side effects can be, the acute ones can be more severe. There's a lot of misinformation out there on the long-term effects from AZEDRA compared with Lutathera, and a lot of that, I think, was the populations that were studied in the trials and the treatments they had in the past. I'm pretty convinced at this point that radiation has long-term risks for things like bone marrow failure or second cancers, and there's nothing magical about one kind of radiation compared to another one, in my opinion. I don't know if anyone else here disagrees, but they all have that risk. Our goal is to treat patients in a way that gets them the most time with their cancer, and to push things back as much as possible. And so we try to dole out treatments and things like that, but they all have cumulative risks in the end, and I don't think they're really that different.
Yes, and just to give you more specifics, when you look at the results of the phase 2 clinical trial that led to the approval of AZEDRA, yes, about 60% of patients exhibit some degree of bone marrow insufficiency, and that happened in between weeks 6 to 8 after the treatment was given. Now, majority of patients were graded as grade 1 to grade 2. Most of you, of course, are not familiar with that, but they are considered mild insufficiencies. 26% of patients exhibit grade 3 and grade 4 side effects related to bone marrow insufficiency. In other words, insufficiency was considered moderate to severe. And by definition, those patients required transfusion of red blood cells in case of anemia, transfusion of platelets in case of thrombocytopenia or low platelets, and the use of factors that induce the activation of the immune system in the case of leukopenias that were associated with the disease. What is interesting here is that in the clinical trial, no patients died because of bone marrow insufficiency after the treatment was given. There was no need for stem cell transplantation, and everybody recovered. So yes, AZEDRA could be tough with the bone marrow, but in reality, it's a side effect that for most part in clinical practice doesn't last that long. Nevertheless, as the other panelists have indicated, yes, there is a theoretical risk for leukemias, bone marrow dysplasia, bone marrow failure in the long term. And of course, to that risk, it adds the fact that patients with pheochromocytomas and paragangliomas frequently have bone metastases. They happen in up to 70% of them. They have been frequently treated with radiation therapy into those bone metastases, and they have a deleterious effect on the bone marrow as well. And yes, patients sometimes have been treated previously with chemotherapy or even with Lutathera, and all those factors added to the risk of those side effects. Now, when you look at the risk of Lutathera causing leukemias and bone marrow insufficiency, and it has been published in the other brothers of pheochromocytomas and paragangliomas, is about 4%. If you look at chemotherapy with cyclophosphamide, vincristine, and dacarbazine, which is the classical treatment for pheochromocytoma and paraganglioma, is about 4%. With AZEDRA, we don't know. There is a phase 4 clinical trial looking at that in the long term, but we know it may happen, and likely will be similar.
All right, thank you. The next question is, can I be treated with Lutathera if I was treated with Azedra? If yes, are there any caveats, and is there any data about Lutathera after having had Azedra treatment?
The short answer is yes, patients can be treated. The same thing applies, that the effects on the bone marrow. I like to explain to patients that our bone marrow is like a gas tank, and we're born with a big gas tank with a lot of reserve capacity. And as these treatments happen, that reserve capacity gets chewed up until eventually the tank is too small. Some patients that happens with a lot less treatment than others. And we've had patients who have gotten pretty much everything we have to offer at least twice, and their marrow still can tolerate it. So we know that as you get more and more treatments, the risk that the bone marrow won't be able to tolerate it increases, but as long as the counts are good, we can still proceed with treatment. There's very little data on Lutathera in general in Pheo Para. There's even less in specifically Lutathera after AZEDRA, but I've seen patients who have gotten it, and similarly, some have responded and some haven't. So I don't know yet if it's less likely or more likely. I suspect that people either respond or they don't.
Yeah, the only thing I would add to that, I completely agree, is also it would kind of take another reevaluation of the patient at that time, especially with imaging. So they would have to get reimaged with DOTATATE and see what their expression is at that time and how things have changed. And also relative, I think everyone is talking about kind of these additive effects of different types of therapies, not just radiation. And so that's also something to keep in mind in terms of the timeline for these subsequent therapies. You wouldn't generally want to, add it on too quickly. But if the patient has had a good response from AZEDRA in the past, has recovered from any of their bone marrow toxicity, and on repeat DOTATATE imaging does still show high expression, that would be probably a good candidate for a repeat therapy, with, as Dan has said multiple times, without knowing what the outcome of that will be.
Right, thank you. So earlier, Dr. Jimenez mentioned the importance of clinical trials. So the next question is, what clinical trial options are currently available?
I can answer part of the question. Likely my colleagues may answer some of the nuclear medicine trials that we have available. So I will tell you about one that I'm quite familiar now, which is belzutifan. Belzutifan is not a radiopharmaceutical agent. Belzutifan is not considered chemotherapy. Belzutifan is a sophisticated medication that targets what is considered by many as the heart, as the core of many pheochromocytomas and paragangliomas that we see in clinical practice, target that is called the hypoxia-inducible factor 2 alpha. In other words, this is a medication that inhibits the activity of that molecule. And it's because of that molecule, for instance, that the tumors are able to spread, are able to grow, are able to create vessels for them to be fed. Many different things that the tumors need, depend on that particular target. It is a medication that is given orally. There is currently a phase 2 clinical trial with belzutifan. It's an international multi-institutional clinical trial. It's around the world. There are 12 countries involved in this clinical trial and 46 centers that participate on it. It's a trial that is trying to bring diversity and knowledge about clinical information related to this particular disorder. I cannot give you any results. I belong to MD Anderson. MD Anderson is the leading site for this clinical trial worldwide. I am the leading investigator, and I participated very actively in the design of this clinical trial some time ago. I'm not allowed to give results. The only thing I can tell you is I like it.
And
And Dr. Jimenez, is that trial, is belzutifan trial still open? For new
This is
patients to enroll?
interesting because people frequently ask questions. So it's a very complicated clinical trial. It's a clinical trial that has several cohorts. They are looking for patients with pheochromocytomas and paragangliomas, amongst others. The initial cohort just recruited all patients that were needed. The cohort required 72 patients, and yes, they were recruited very fast. It was a very successful clinical trial. As you can imagine, this is a rare condition, but it happens all over the world. And this trial is open in countries like Russia, like China, like Japan, like Turkey, like France. So these are countries that, of course, have many patients. So the recruitment was really, really fast, which is wonderful because the analysis is going on for all the patients who participated in that cohort. There is a second cohort of patients looking for pheochromocytomas and paragangliomas, but it's quite selective and is in phases. Right now, that particular cohort is looking for patients who have metastatic pheochromocytomas and paragangliomas with a clear signal for pseudohypoxia, but that signal shouldn't be SDHB mutations. So it's looking for the rare cases, SDHC, SDHD, SDHA, SDHAF2, is looking for patients who have hypoxia-inducible factor 2 alpha mutations and other ones. And in that sense, it has been a cohort that is recruiting very slowly. Nevertheless, if those mutations are present in any of you, of course, something to consider because it's a trial that will consider your participation extensively. Patients with apparently sporadic disease, patients with no mutations, no, they are not also included in that particular part of the trial.
Thank you. And I think, Dr. Mittra, you were going to chime in on the topic of clinical trials.
Oh yeah, just to again reiterate the one that I mentioned before. It's I think the only one that I'm aware of on the nuclear medicine space, which is the NIH trial for Lutathera and Pheo Para, and I definitely would advocate for patients to enroll in that because again, people are using it off label, and as Dr. Pryma has said, we really need objective evidence for it. So this is the trial to do that. So I would advocate for people and their providers to refer patients to that. I think it's only half recruited so far, so there's still space for that to happen. Dan, do you know of any other nuclear medicine trials for Pheo Para?
Not in the US. There's in Japan, they're testing MABG, which is an alpha emitting MIBG analog, and we're trying like crazy to get that open here. So hopefully in the next year or so, we'll have something open here for that. But that'll be an early small trial, but otherwise nothing specifically now.
And I just wanted to mention then other possibilities coming from clinical trials that are currently closed, the tyrosine kinase inhibitors. There are some medications that are able to prevent growth of these tumors, to decrease the vascular formation. They only work for some time, but they can give you time and they may control the disease. And sometimes they may work for longer than what is used to be the action of the medication. So to give you an idea, some of these medications work for 1 year. In some patients, they may work for 2, 3, or 4 years. So they are options. And names are, for instance, sunitinib, which is also mentioned in the NCCN guidelines as a potential treatment for pheochromocytoma and paraganglioma. And this is based on the results of the first MAP clinical trial that was performed in Europe, not in the US. And the clinical trial demonstrated that, yes, sunitinib, when compared with placebo, was able to have an impact in an aspect that we call progression-free survival or tumor stabilization for some time. So that's why it was interesting. I haven't seen the final publication, but the results, of course, are positive, and they bring another potential medication to the pipeline of pheochromocytomas and paragangliomas. Cabozantinib is another interesting medication. There are no comparative studies in between sunitinib and cabozantinib. The belief is that cabozantinib is stronger in that particular regard, and the phase 2 clinical trial is currently under evaluation for publication as well. So we have potential other medications for this. And finally, although there are no other clinical trials in nuclear medicine focused for pheochromocytoma and paraganglioma exclusively, I am aware that there are some clinical trials that may allow the participation of some patients with pheochromocytomas and paragangliomas, although they are trials that are mainly focused on neuroendocrine tumors of gastrointestinal origin. I don't know of a clinical trial that is with a medication, and I'm not sure if this is the right name or not, Dr. Mittra, Dr. Pryma, you may correct me, AlphaMedix, they may consider the participation of pheochromocytoma and paraganglioma patients.
All right, thank you. The next question is, are there any SDHB-specific treatments that are shown to be effective in the treatment of paragangliomas?
Well, there's reason, I don't know if it's fully shown, to Camilo's point, but there's very good reason to believe that belzutifan may be effective because of the mutation that leads to development of Pheos in patients with SDHB is very similar to the hypoxia caused by HIF1 mutations, in which belzutifan has already been shown to be effective. So we have a lot of reason scientifically to believe it. We have one patient so far who's receiving it, and it's too early to know. But I think that that's something that has potential to specifically work, not just SDHB, but patients with SDH mutations in general. But I can't wait to see the data.
And I cannot comment again. I like it.
I think that's a comment.
All right, thank you. Our next question is from a patient. I have received 500 millicuries of Azedra with partially positive results. My doctors recommended another dose of 300 millicuries, but I don't feel very safe. The question ends there, but I think the sort of implied question is your thoughts on whether this patient should continue with the second dose of 300 millicuries.
I mean, it's definitely hard to answer that without a lot more information, and without seeing a patient. I'll say that in the phase 2 trial, what was tested was 2 treatments of up to 500 millicuries, 3 to 6 months apart. And so most of the time that's our approach, but every patient's different. And there are some patients where their disease was moving very slowly, and with one treatment, we saw that it definitely knocked it back, and we were able to kind of hold off and do that second dose much later. Other patients, we were pretty convinced that we needed to give more sooner. I think now our hands are a little bit forced, and in fact, I've had the conversation with some patients where, say, in the past, I would have said, like, let's hold off and stretch that period, but now that it's not going to be available, let's move forward. So I think if a patient benefited and tolerated it well, and I think getting that second dose now before it's not available may make sense if all else is equal, but hard to know in that specific situation.
Thank you. The next question covers the topic of insurance, and I think this was partially touched on previously. My insurance covered Azedra. Will it cover a different therapy? What can I do if it doesn't?
Well, I'll start this discussion, although the doctors have more practical experience with this. But again, we are working with the medical advisory board to put together a form letter that you can print off and take to your provider, and that provider can then include that in the documentation that they provide to the insurance company about the off-label medication that you will be prescribed, hopefully, going forward. So that should be on the Advocacy Task Force webpage soon. We'll also announce it on social media when it's there. And then again, as I mentioned, I'll be putting together a list of the consumer advocacy branches of the state departments of insurance throughout the United States. This will probably be less of an issue worldwide. And of course, Azedra wasn't used outside of the United States. So but that will be on the website soon as well. And again, if you get pushback from the insurance company, unfortunately, at the end of the day, it's you and your doctor that will have to do the heavy lifting there. We'll give you all the tools that you can, but at the end of the day, you'll be the one fighting with them. And the clinical care guidelines also on the Advocacy Task Force webpage are a really important piece of that too, because they do outline what we consider to be the standard of care for Pheo Para, and it includes a lot of therapies that would be currently off-label use.
Yeah, I would just add that in my experience, most insurance companies will ultimately pay for most of these treatments given the data and the need. But it's almost never their knee-jerk response to say, yes, we'll pay for it. So some fighting is going to be required.
Yeah, and I would also add that there's a lot of regional differences. So what one experience is in one part of the country or with a certain insurance provider can be very different in other areas. So, if you have friends or colleagues in different parts of the country and they've had one experience, that doesn't mean that that's going to be your experience. So you just have to, again, kind of address it locally.
And some pharmaceutical companies have programs to support patients, financially speaking. That mainly happens with the tyrosine kinase inhibitors, cabozantinib, sunitinib, pazopanib. There are other things that we can explore. Now, to be honest, yes, I had one patient who was candidate for us, or who is candidate for AZEDRA. The option doesn't exist. And her insurance was very clear. Only an FDA-approved medication would be provided. And we try in different ways. She had the means, so she's buying the medication. But that's not really what happens to many people. And what I mean by that is not many people are able to afford these medications. They are quite expensive.
Do you want to take a moment, any of the doctors, to discuss the actual cost of both therapies, both Azedra and Lutathera, if you know? I think we've gotten some questions about that in the past, and this might be a good time.
If you're comparing the cost of 4 treatments with Lutathera to 2 treatments of Azedra, I think the Azedra, just the acquisition cost, not everything else, was a little bit higher. They're both in the hundreds of thousands of dollars. So it's not like one was $50 and one was $1 million. So similar ballpark, but I think the Azedra was higher.
Yeah, and
I
also
simply mention this. Oh, go ahead.
I'm sorry. I put it in the Q&A that the other difference is that since Azedra is an inpatient treatment, the reimbursement is bundled, which is a little bit different how the hospital views that reimbursement. whereas the Lutathera is an outpatient treatment, and so it's reimbursed a little bit better, and so that also kind of affects that.
And
bottom
just to
line.
give you specifics from MD Anderson, I cannot talk by other institutions, but the last time I heard about prices at MD Anderson, the cost of AZEDRA was for full dose. What I mean by that, the equivalent to 1,000 millicuries, which is 500 millicuries twice, about $300,000. For Lutathera, which are 200 millicuries 4 times, each dose 2 months apart, usually, the equivalent was $250,000.
All right. I do want to address some of the questions that have been in the Q&A, and also we also received a comment in the chat on the topic of clinical trials. So somebody wrote in, NIH has a clinical trial, apologies if I pronounce this incorrectly, a phase 1/2 trial of PB212 VMT AlphaNet in GI neuroendocrine tumors in Pheo Para's previously treated with radioligand therapy. Dr. Lin is the PI, so just wanted to share that. And then also on the topic of clinical trials, somebody asked in the Q&A, are VUSs, variations of unknown significance genetic mutations, are those included?
I think towards in the belzutifan trial specifically was the question, I think.
Okay, for the belzutifan trial?
If it is for belzutifan, no. They have to be clearly pathogenic mutations. So a variant of unknown significance is not considered a criteria to participate.
Thank you. Next question that we have in the chat, are there any trials directed at methylation?
So yes, there is one that I think is quite important, is at the NCI. Well, it's not only NCI. In reality, there are 2 leading institutions, the NCI and the Dana-Farber in Harvard in Boston. The principal investigators are Dr. Azedra del Rivero and Dr. Kimberly Perez. It's a clinical trial that is sponsored through the National Cancer Comprehensive Network. In other words, it's a clinical trial that also involves other institutions, big cancer centers in the nation that are part of that network. The network in reality includes majority of the or all the leading sites in researching cancer in the US. And it's a clinical trial that is looking at TEMODAR and PPAR inhibitors as a potential treatment for pheochromocytomas and paragangliomas. We don't have any results, to the best of my knowledge, presented yet at a scientific meeting. I have not seen anything saying this. The concept is actually quite interesting, given the fact that, historically speaking, TEMODAR has demonstrated in some patients to be perhaps effective. And if you look at TEMODAR, is the equivalent to dacarbazine in the cyclophosphamide increased in dacarbazine protocol that is classically used for chemotherapy for pheochromocytoma and paraganglioma. And they believe, historically speaking, is that of all the 3 medications, dacarbazine is perhaps the most effective one against this cancer. In other words, that clinical trial is a clinical trial that, yes, it will provide us with very good information on how those medications and how methylation may determine the behavior of these tumors.
All right, thank you. I think we have time for maybe one more question, which is, what is the role of lower doses of MIBG, which may have been used commonly in many other countries, along the lines of 200 millicuries?
Yeah, I mean, there was an interesting role in the past, but with it unavailable, its lower doses are equally unavailable to higher doses. I think there definitely was efficacy in patients that we see. In patients with SDHB mutations, we found in our own data that those patients clearly seem to benefit more from the higher doses than the lower doses. But in other patients, it seemed to be more of a just either one worked. It's just getting the cumulative dose in over more treatments versus fewer.
And just to add in that, don't have the expertise that Dr. Mittra or Dr. Pryma have in nuclear medicine. I just have the clinical experience and the expertise on the nature of pheochromocytomas and paragangliomas. And I have treated several patients with AZEDRA over the last 3-4 years once the medication became FDA approved. And in my practice, because of X or Y reason, there are patients who have received doses that are not the classical ones. I have patients who have been treated with 200 millicuries. Why is that? Because the dosimetry says that we have to use a dose that is lower than what is recommended. To give you an idea, I mentioned to you that all individual who is 84 years of age, in his case, given the fact that he's very little, the dose that he used was not big. It was about 200 millicuries total, and the response was wonderful. Then I have other patients. Recently, about 2 days ago, I saw another lady who is in her 80s. The second dose, because of some renal issues, was lowered to 80 millicuries. And she came for evaluation after the second dose. And it's quite interesting because radiographically speaking, her disease was progressive, was enlarging. No, it's not enlarging any longer. And conversely, we saw some lesions getting smaller and no progression. So there is a stabilization. So although the clinical trial indicated that the dose is 500 millicuries, and the phase 1 clinical trial led to that information clearly, looking for the best benefits with the higher degree of safety possible related to the maximum dose. In reality, yes, you may consider in routine clinical practice the use of lower doses at some point, simply that is just based on experience. And what I'm bringing here is for people not to be fixed with a particular dose, because at the end, all of us are different. And still a low dose may work perfectly well. And that could be the same case for conventional MIBG. And this is important to clarify when we talk about that misleading information. Well, at the end, not everybody is treated with the maximal doses. And perhaps at the end, it's a clinical decision. And I suppose a clinician with experience, a nuclear medicine doctor with a lot of experience in this field may say, no, listen, maybe for you, I'm going to use lower than usual. Perhaps that's the best way to do it. Who knows?
All right. And with that, we are out of time. Thank you to our panelists, especially Dr. Jimenez, Mittra, and Dr. Mittra and Dr. Pryma, for your time and dedication to our patient community. This webinar will be available in a few days on YouTube and on the website, and we will also transcribe today's questions and link to the answers in the video. If you want to learn more about Azedra, please take a look at our Advocacy Task Force webpage, where we've posted links to 2 recent videos Pheo Para Alliance has produced about Azedra. Just go to pheopara.org, choose Connect from the top menu, click on Take Action, and look for the Advocacy Task Force link. If you'd like to stay informed about this topic and other events and opportunities to get involved, sign up for our e-news and follow us on social media. If this information has been useful to you and you are interested in donating, you can do so at pheopara.org/donate. Thank you to everyone who attended today, and have a fearless weekend.